I see your message as well. And I'm getting a virtual meeting disclaimer, which means we've started, which is great. Welcome to everyone, and thank you so much for being with us this morning. I'm Dr. Tracy Liu. I'm the director of the Division of Research at Kaiser Permanente, Northern California, and I'm the chair of this study and of this meeting. So I'd like to welcome you and thank you so much for being with us. The task being undertaken by this committee of the National Academy of Sciences, Engineering, and Medicine is to assist NIH and HRQ, the sponsors of this study, in filling evidence gaps within the recommendations of the U.S. Preventive Services Task Force. The formal statement of test can be found on the project website, and we'll take a minute to go over it as we begin. I want to note that this is an open on-the-record session. We'll post the audio files and PowerPoint slides on the project website in a few days. I'd like to remind everyone that this is an information gathering session. That is, in the course of making its findings, conclusions, and recommendations, the committee is in the process of assembling materials that it will examine and discuss. Therefore, I will ask everyone here today to be extremely mindful of the fact that the committee's made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the academies or of the committee. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee must then respond to this review with appropriate revisions before it's considered an official Academies report. So before turning the meeting over to our invited guests, I'd like the committee to very briefly introduce themselves. So just give your 5-second introduction, and I'll go in alphabetical order by last name. So Kathy Bradley.
Good morning. I'm Kathy Bradley. I'm the Associate Dean for Research at the Colorado School of Public Health and the Deputy Director of the University of Colorado Cancer Center.
Thank you. Ted Gagne.
Ted Gagnitz. Hi, everyone. Professor, University of California, San Diego.
Yan Wang.
Hi, everyone. I'm Yan from NYU School of Medicine, Associate Professor.
Great. Preeti Kochhar.
Hi, everyone. I'm Preeti Kochhar from the National Library of Medicine at NIH. I'm a technical information specialist working on data science.
Great. Ann Kurth.
Hi, Ann Kurth, Dean of the Yale School of Nursing and Professor at the Yale School of Public Health.
Tianjing Li.
Hi, Associate Professor at School of Medicine, University of Colorado Anschutz Medical Campus. Good morning, everyone.
Venkat Narayan.
Yeah, I'm Venkat Narayan. I'm in the faculty at Emory University.
Great. Wanda Nicholson.
Good morning, everybody. I'm a professor of obstetrics and gynecology at the University of North Carolina at Chapel Hill and work out of the Center for Women's Health Research.
Great. Elizabeth O'Feely.
Good morning, Professor of Medicine at Morehouse School of Medicine and Chief Medical Officer for the Morehouse Choice ACO.
Terrific. Nico Pronk.
Good morning, Nico Pronk, President and Chief Science Officer at Health Partners Institute, Minneapolis.
Bob Wallace. You may need to take yourself off mute, Bob.
I'm sorry, Tracy. Are you talking? Did
you got it.
Yeah, okay. Bob Wallace, Emeritus Professor of Epidemiology and Internal Medicine, University of Iowa.
Good. Let me take a moment to give our National Academy staff a heads up. So Kathleen Stratton.
Hi, good morning, everybody. Kathleen Stratton, Study Director for the project.
Great. Alexis Waterman.
Morning, Alexis Wodowitz. I am an Associate Program Officer on this project.
Great. Asia?
Hi, good morning. I'm Asia Coltrane and I'm the Senior Program Assistant.
Okay, and may I look at you, Rose Martinez? I see you hiding down there. Oh, and
here. Yes, Rose Martinez. I direct the Board on Population Health and Public Health Practice. Good morning.
Okay. And so welcome. Thank you thank you all so much for being with us. Welcome to our guests as well. I want to take 1 minute before we start with the first panel to orient us all a little and just lay groundwork for what we're about to discuss this morning. So actually, let me move something here. And I'm going to share my one screen here. I have only 3 slides, so this will be really easy. Here we go. Let me share that. So just to touch briefly on the statement of tasks. So this committee has been asked by NIH and HRQ and the National Academies to produce a report that will outline how research gaps are described in the current U.S. Preventive Services Task Force portfolio, to propose a taxonomy for describing research gaps and apply it to a sample of existing task force evidence gaps and I statements, to describe the types of research studies needed to inform different types of evidence gaps, and most broadly, to propose ways for prevention research funders, including NIH, but also other funders, and recommendation developers, including the task force, but also other recommendation statement developers, to enhance their partnership, to accelerate research, to close important gaps in prevention. And I'll just make a note that this first panel this morning is helping us address our task broadly on this 4th bullet in the task. As we think about how to address evidence gaps and who is involved, we can think about major stakeholders. Some of these are guideline committees like the task force, others are research funders, including NIH and other funders. And a third group of key stakeholders are researchers. So in this workflow, in order to orient our thinking, we've just outlined some of the different types of activities that guideline committees, research funders, and researchers may participate in. And it's our job in this first panel this morning to learn more about exactly what the guideline committees do, including the task force, in terms of identifying, describing evidence gaps. We'll hear from a research funder in terms of how that funder may interact with guideline statements or set priorities, but also about the process of issuing funding opportunity announcements and developing relationships and infrastructure for research. And third, we'll hear from a researcher about responding to funding opportunities and how they identify and prioritize evidence gaps and develop the relationships and infrastructure needed for sustained research in these fields. So I'll stop sharing, and I'd actually like to turn back to our first panel. So just turning back to this. So our first panel will discuss the ways the task force, NIH, and the research community interact and influence each other to fill research gaps in clinical prevention. We have chosen colorectal cancer screening as our topic, and I'd like to welcome Drs. Chaik Dubany, Paul Doria-Rose, and Doug Corley. And I will give each of you a minute to introduce yourselves, and then we'll start the panel. So may I look at you, Chaik, and go ahead and give your self-introduction.
Well, thank you, Tracy, and for the committee for inviting me to this panel presentation. I'm Chaik Dubany. I'm a professor of family medicine, but also of medicine at Mayo School of College of Medicine and Science. I direct a number of programs at Mayo, but also serve in U.S. Preventive Services Task Force. Glad to be here.
Thank you so much for joining us. Paul.
Good morning, everyone. Thanks so much for the invitation. My name is Paul Doria-Rose. I'm an epidemiologist, and I'm the chief of the Healthcare Assessment Research Branch within the Healthcare Delivery Research Program at NCI.
Thank you, Paul. Doug.
Hi, thanks so much for the invitation. It's such a privilege to be here. My name is Doug Corley. I'm a gastroenterologist and an epidemiologist. I'm also a research scientist at Kaiser Permanente Division of Research in Northern California. I'm an investigator there, and I also work with a number of other investigators as the director of delivery science and applied research.
Great, thank you so much. So we'll go ahead and get going with our first panel. After the presentations, I'll moderate discussion between the panelists, and then open the meeting up for first comments and questions from our committee members. We'll also then invite the members of the task force to join the discussion. And why don't we go ahead and get started with Chai? Thank you so much.
So thank you for inviting me. And I thought to kind of guide my comments, I have some slides as talking points. So just a disclaimer, a lot of what I'm saying, not necessarily those are the views of the task force, although I'm a member of the task force. I do a lot of work in the area of colorectal cancer, and I've had the privilege of working with a number of people on the screen here. I think it's really important to, I know you've heard from Amanda Bosky, you've heard from Carol Mangione about the process the task force uses to identify evidence gaps and some of the areas of opportunities, I believe, for improvement in this area. But it may be good to sort of ground this a little bit, because at the end of the day, when I think about sort of the process the task force goes through and the opportunities it provides for us to provide clarity, I wondered why you picked colorectal cancer, but selfishly, I'm glad you did. Because I see colorectal cancer as sort of a disease model that has a lot of the attributes that will allow you as a committee to look at this topic and say, what do we know? How do we apply it in this context? Where are the opportunities? How do we provide the clarity needed? And so I was really tickled about your choice. But if you can allow me for just a minute to introduce a very familiar aspect of this, which is the principles of screening, or criteria, if you like, of screening. I won't go through any of this at all, just at least to show you where my brain was as I thought about how to respond and make some comments here. But I like the way that the UK National Screening Committee organized this, and it's not all of the things that I added equity because of my personal interest there, and I hope it's of interest to you as well. But they organize it along the context of the condition, the test, and the treatment. And to me, this is sort of the way I think about screening and how you can look at where the opportunities are to have an impact in disease prevention, but also opportunities for areas of gaps in the evidence to address. And I keep this for just a second and then move on to the next screen. But what I want to do highlight here, for instance, is the areas in which the task force doesn't necessarily focus their recommendations, but one that has a tremendous impact in the effectiveness or the impact or reach of the recommendation. That's the area of implementation. So acceptability, feasibility of the recommendation, and how it's implemented in practice has an enormous impact. But of course, the disease process, natural history of the disease process, and the detectable conditions or risk factors are enormously important. I'll go into those in just a minute. Again, I found it really tempting. I couldn't resist bringing this up because colorectal cancer is sort of this matrix, right? If you look at it, there's sort of a screening piece to colorectal cancer. But let's not forget, there's a prevention piece to it. We know a lot about colorectal cancer risk factors and prevention opportunities because we think we know a lot of colorectal cancer is driven by lifestyle factors. So what if we can change those lifestyle factors? We can make enormous difference. But we have a recommendation for aspirin. And so some of these are in progress. As you know, it's a draft recommendation. For the screening recommendation, you see the letters there. So it's almost an alphabet soup, right? A, B, C, B, C, I. There are actually two I's there. It's just put the two of them together. But when I think about this again, it comes down, as we've discussed before in the last meeting, to the benefits and harms. And at the end of the day, when you talk about screening prevention, it's all about the benefits and the harms and that balance between the two things. And that is really the way the task force looks at the evidence. And so the question then is that how is the evidence gaps or the quality of the evidence balanced across these two areas to inform us and make it an informed decision about the right way to approach it? And I know many of you are former task force members, Anne and others. So this is really nothing that's new to you, but I found it tempting. I like to doodle, and this is a result of doodling. And so when you think again about that, to the left, you have the age, right? So how do we arrive at the age to start? And how do we arrive at the age to stop? And it seems really simple, but these are really areas that are very challenging to pin down and how to make that pragmatic decision between them. Again, this lends itself to what really is the evidence and how do we decide where to set that bound? Do we set it for one group versus a different group, right? And these are really not non-trivial decisions that the task force wrestles with, literally wrestles with to come up with a decision. So again, underpinning all of this is the analytic framework. So this diagram on the top is the matrix through which the evidence practice centers work through to come up with the evidence, and they also identify the areas in which the evidence is lacking. And every step of this diagram that you see from the left to the right, opportunities to understand what the screening process is, how it works, the accuracy and effectiveness, or safety and effectiveness, and what pathway we can go to be able to make a recommendation, with either directly on line 1, labeled 1, or through that path you see colonoscopy and all the various tests to get to a point where we say, okay, this works well, and we're really confident about it. So really certain about it, so it's an A. And we're certain but not so sure, a little bit of a B. And so I think this is a process you saw on the prior slide with all the colored alphabets or letters. This is about me thinking through this, because when I think about this, again, it's about prevention, risk assessment, or risk stratification, detection, screening, follow-up surveillance, and treatment. All of these are part of the screening process. And again, if you think about it, each of these, and I'm glad Alex is going to give you sort of that taxonomy to make all of this clear, each of these then provide an opportunity. But look at the top, right? It's about the population, the intervention, the benefits, the harms. And so all of those things in the middle then is sort of this matrix, multi-dimensional piece in which we have multiple levels. So if you think about a socio-ecological model, plus implementation equity issues, again, I can't resist bringing that up. And I hope it's of interest to you as well in this era of awareness about racism. All right. So it's a little bit of a different flavor on this. And I think about this, and this is not the decision matrix, but I think about it in terms of decision matrix, right? So the importance of the clinical condition, again, going back to the criteria for screening, the analytic framework, what is amenable to screening. And this is an area where we struggle in terms of being able to educate the public. It's not your charge, but I find it tempting to let you know, people think every screening should be done for everybody, right? But again, it comes back again to the balance of harms and benefits, and where the task force tries to thread that needle to be able to guide the public in the right approach to take in making recommendations that are meaningful and have the effect of improving the health of all Americans. So again, the assessing the evidence goes back to that PCOT structure. Again, if you see the stuff bold, italicized, that is CHIKE. So that's my personal view mostly. But I think the inclusiveness of the clinical evidence that goes into this evidence is really important, and an area of gap and necessity for us to understand and apply it better. I think that's a new opportunity in my view for you outside of the routine work that we've done to this point. You've seen this slide before, just edited a little bit. Recommendations are in primary care, that's a setting. So if we go back to this slide, you see the setting there on the bottom right. Primary care, we apply the Human Development Index as sort of a way to see where the studies are coming from. Are they applicable to US setting? But you can also argue, is that the right way to do it? But that's the way we do it. And then the population, asymptomatic people without obvious conditions, and the design should be strong. And I think that's where it is. You know, we don't stick only to randomized trials, but that obviously is the preference if we had it. Again, you've seen this before as well. I'm not going to belabor it, but this is not, we don't on the task force decide unilaterally what the evidence is. And as part of our stakeholder engagement, and Marty's on the line as well, we get input from everybody to see where are the gaps, right? Through the draft process, we get input from all our stakeholders to understand where are the gaps, where are opportunities to call out the evidence gaps. And so all of that goes into the matrix in terms of how those are highlighted in recommendation. And again, this depends on the maturity of the topic and also the evidentiary chain. Colorectal cancer is a very interesting example. We think it's very mature, but you see some examples, it seems like we are not actually that mature. but we have enough to at least help us get to the point where we are. And so if it's something that's really not a lot of evidence behind it, you get this I statement. If it's mature enough, you get an A or a D, right? Somewhere in between is sort of the B's and C's. But the social context is also important. Again, just something I said before, in the interest of time, I'm going to move forward quickly. That it's the review process embeds the evidence identification process into it. Going back to this slide and just some points to make. Again, taking up my role as on the task force, I think defining what is screening is just as important as knowing what the gaps are, because I think that's also an area where things have evolved, but the process definitions haven't evolved with it as well. Again, embedding issues of health equity are equally important. I'm just going to leave this slide and stop. And our current recommendation on colorectal cancer screening is still in the works. It's not been published yet, but you may see some of these in that recommendation, maybe on the draft version you saw it. But you see that the questions look like we have a lot to learn, right? Randomized trials of different screening strategies, what works, how do they work, what's the safety and the effectiveness in different populations. So that is sort of the process we go through. And we wish we can list every bit of the evidence gaps, but we have to prioritize. That's where the matrix kind of comes in. We don't have a formal matrix, but it's in some way we get to a point through that matrix of prioritizing what is most important, either from understanding the best way to make a recommendation or understanding the best way the recommendation can be implemented in practice by primary care clinicians. So I'll stop there. Thank you for the opportunity.
Great, thank you so much, Chaik. We'll go ahead and move on to Paul Dory Rose and then to Doug Corley, and then we'll have discussion afterwards. So we'll go ahead and make that switch.
Great, thanks so much. Again, thanks for the invitation to be with you today. So I'll be talking about how NCI as a funder is thinking about addressing evidence gaps. Again, like Chaik, I'm happy that you chose CRC screening to be your example for today. If I can have the next slide. So, I think in addition to, and this is stating the obvious, kind of reviewing the literature, understanding what evidence we have, what evidence we don't have, one thing that we at NIH and NCI spend a lot of time thinking about is what we have in our grant portfolio. So, we do analyses of the topic areas for applications that are coming in, and among those topic areas, what applications are being funded. And if we notice that in a content area that we judge to be important, we're seeing either few applications at all or seeing a reasonable number of applications, but for whatever reason, fewer being funded. One thing that we'll often do is publish funding opportunity announcements to address this, to stimulate more applications, and hopefully, ultimately, the goal being to stimulate more successful applications. And these funding announcements come in different flavors. We have requests for application or RFAs, which have a narrowly defined content area with set aside funding. And this includes large cooperative agreement funded networks, a couple of which I'll be talking about in a bit more detail shortly. And these are networks that I've been directly involved in scientifically. We have program announcements or PAs, which are a way to call out NCI's interest in specific high priority areas. And then the kind of new kid on the block, we've been increasingly focused on notices of special interest or NOCIs, which have been around for a while, but are becoming much more common. And I kind of think of these as kind of a PA light. And I do also want to emphasize that it's not at all required to apply under a specific FOA. The parent announcements are fine mechanisms to submit applications under. We recognize that many great ideas are originating outside of NIH. And in fact, the majority of what we fund is actually coming in as investigator-initiated applications. So next slide, please. So then I'll talk a little bit more about a couple different cooperative agreement funded networks that I've served as the project scientist for as examples of how NCI's priorities for addressing evidence gaps can align well with those of groups such as the USPSTF that are making clinical prevention recommendations. And these networks that I'll be talking about are funded through the NCI Division of Cancer Control and Population Sciences, the Prosper Network through my program, the Healthcare Delivery Research Program, and CISNET through the surveillance research program. Next slide. And CISNET is obviously very well known to the task force, having participated in multiple cycles of modeling analyses in support of the development of multiple cancer screening recommendations. It's focused on comparative simulation model using the best available information about disease natural history and screening test characteristics and efficacy to project the impact of multiple different screening regimens. And the comparative modeling aspect is important in that it gives us some sense of the uncertainty regarding the different models' estimates. So if there's similar results between the different models, then that's reassuring. But if model results diverge, then that can indicate areas, for example, where a better understanding of disease natural history is needed. And each CISNET grant includes 3 to 6 different modeling groups. The colorectal cancer group includes 3, the MISCAN, CRC SPIN, and SIMCIRC models. And next slide, please. And I'll talk a little bit about the PROSPER network, which is currently in its second 5-year funding cycle, which, as Chaik was talking about, is in the framework that the task force uses. PROSPER was developed with the understanding that screening is not a single test, but a complex process that's dependent on multiple steps. So we have to know who's eligible, performance of the screening test and interpretation of the results, diagnostic follow-up of those with abnormal screening examinations, and then treatment of malignant cancers or benign precursor lesions that are diagnosed. And successful completion of each of these steps is necessary for maximal screening benefits to accrue, and then conversely, breakdowns at any point in the process, whether it be failure to screen, failure to detect a cancer by screening, failure to conduct appropriate follow-up, or failure to treat, can lead to suboptimal outcomes. And these failures can be due to either patient noncompliance or failures on the part of medical providers or health systems to recommend and conduct appropriate testing and treatment. Next slide. So in the second funding cycle for PROSPER, we have 3 research centers, one each focused on cervical, colorectal, and lung cancer screening. And each center includes 3 to 5 different healthcare systems which collect data on the entirety of the cancer screening process for the cancer of interest. So in total, we have in the network 10 different healthcare systems and over 3.5 million individuals included in the data. And in this cycle, we have a few specific emphases, including, you'll be glad to hear, Chaik, a focus on underserved patient populations, including racial and ethnic minorities, those of lower socioeconomic status, and then also a focus on trans-PROSPER research, doing research across the cancers to think about kind of common conceptualizations and measures for assessing systems levels factors. So, how are different health systems doing and what distinguishes a system that's delivering screening well versus not so well, and then also screening quality. How do we define what a high quality screening exam is, and how can we think about this in kind of common ways across the different cancers that we screen for? And then finally, it was the intent this cycle of PROSPER to encourage development and pilot testing of interventions to improve the screening process, although how this is going to look in the current pandemic situation is a bit under discussion at the moment. Next slide, please. So then this slide just shows the alignment between the evidence gaps as indicated in the current draft of the colorectal screening recommendations that Chaik also just showed, and then also the goals of PROSPER and CISNET. So I've noted with either a check mark if the network addresses that gap area or an X if it doesn't. And I won't go through all of the gap areas again since Chaik did, but I'll just make a few comments about, kind of how the networks that I'm talking about align. So neither of PROSPER nor CISNET is involved in the business of conducting large-scale efficacy trials, randomized trials of cancer screening strategies. Though NCI's Division of Cancer Prevention does have a long history of supporting these kinds of trials. And both networks do conduct research in comparative screening effectiveness more generally. And then you can see from there that CISNET really does have a focus in each of the other gap areas. And while PROSPER covers some of those gap areas, and really in the areas that it doesn't, the exceptions are research regarding specific screening modalities, specifically multi-target stool DNA, the CT colonography, and emerging technologies which aren't really used to any appreciable degree in any of the participating healthcare systems in the network. Next slide. And then this and the next slide shows some examples of how PROSPER and CISNET are addressing these evidence gaps. So this is an example from the first cycle of PROSPER that looked at among individuals who had a baseline negative fit test that looked at then the patterns of adherence over the next 3 years, stratified by which health system, with blue representing the proportion who remained adherent to annual fit over the duration of follow-up, red then those who received some additional fit testing, but not every year, and then green those who had no subsequent fit testing at all, the so-called one and done group. And this shows extreme heterogeneity in the different healthcare systems with consistent screening ranging from just 1% to over 50%. Next slide. And then this is an example from the modeling report that CISNET just did in support of the current draft of the colorectal screening recommendations for the task force, with the bar graph on the right showing model averages for life years gained with different screening modalities or combinations of modalities. And then notably here, the dark blue piece of the bar, of each bar, indicating the amount of gain that's associated with beginning screening at age 45 as opposed to age 50, which was obviously a major consideration of the task force this cycle. Next slide. So then in my last couple slides, I just want to mention a few resources available at NCI. This slide shows links to both the Healthcare Delivery Research Program and the Division of Cancer Control and Population Sciences websites. And both of these have links to our active funding opportunity announcements. So here I show a screenshot from the HCRP website with the link to our active FOAs circled. Next slide. And then here I just wanted to highlight a few FOAs that are relevant to clinical prevention broadly, so not solely related to colorectal cancer here. So the first is a PA focused on increasing screening uptake with a specific emphasis on addressing health disparities. Next is a NOC that's concerning de-implementation of low-value clinical practices, and the former iteration of this announcement had a focus on overscreening in particular, and now has a broader focus, though still interested in and accepting applications related to overscreening. The third is a PAR focused on increasing HPV vaccine uptake with options for R01, R3, and R21 applications. And then finally, I wanted to mention the Axis Network, which is an active network aiming to develop multi-level interventions to increase colorectal cancer screening. And while it's not accepting any additional applications, I did want you to be aware of it as another cooperative agreement focused on colorectal cancer screening. Next slide. So this is just my contact information if you'd like to get in touch, and looking forward to the discussion. Thank you.
Thank you so much, Paul. Let's go ahead and switch gears, and we'll look to Doug.
Just share screen. Can you see that?
Yes, we can.
Great. Again, thank you so much for the invitation. I'm going to echo some of the things that Paul and Chaiken mentioned, but then use them a little bit more for some pragmatic examples. The perspective of this, trying to be able to present from, was that requested as a researcher. In addition to standard roles as an investigator, I'm the lead investigator for the PROSPER Colorectal Cancer Consortium. So that's a 4-site consortium that's within PROSPER. And then also I help to be able to coordinate about a 20-person gastrointestinal research group within the Division of Research that has several investigators, and we talk about these topics a lot. So let's just, I mean, one of the first things is understanding like what's happening within a particular field. So if you're interested in being able to go after colorectal cancer, you can say, well, what is currently happening? And there's aspects, this was a modeling study that was previously done, looking both at the trends of colorectal cancer over time, and then what the relative influences are. It's always striking what the influences of screening. Again, this modeling study actually only went through about 2005, but it provides somewhat of an idea both of the changes in incidence over time, as well as the fairly substantial residual impact of cancer. So if you're saying something along the lines of we want to be able to get cancer deaths down as much as possible or close to zero, then saying what should we do, after we kind of go after these obvious targets. Paul had mentioned, and overall model to be able to look at finding kind of like where most deaths can occur that can guide research. We have found this to be one of the most helpful methods, and there usually are a few areas if you have tools already in your toolbox that you can use, such as screening or prevention that have been identified. If you don't have those, then obviously the research may be towards trying to be able to identify what the risk factors are or whether or not there are effective methods for diagnosis or treatment. But if you have them, then some of the questions might come around like failure to screen, like why are people not being screened if you have effective methods? Failure to detect. So if you are screening someone, but the screening test did not identify the cancer. There's a failure to follow up or treat. So people such as having a positive FIT test for colorectal cancer screening, but then they did not get a follow-up colonoscopy, for example, or they had the follow-up colonoscopy, but then they identified a cancer or a preneoplastic lesion, and that was not treated. Why did that happen? And then there are also these early failures around the risk assessment part and being able to get people into screening in general. So that can conceptually is how to be able to do it, but how might something like this actually be operationalized? And there's a realization that there are different perspectives. Someone might think about this differently if they were a patient oriented researcher, if they were a societal or payer oriented researcher, if they were within a healthcare system. One of the ways that we had taken it was the clinical view. I'm a gastroenterologist, so I do cancer screening. And one of the questions that comes up every day might be something that would be interesting for research. And there's, and as well as the ones that we come to discuss within our group, where you find that are kind of like the biggest patient challenges. So some of those that had come up were, do wide variations in perceived quality matter? This is maybe a little bit of an inside baseball topic 10 years ago, but I think it's come more into the mainstream now, is that, there are wide variations for a gastroenterologist who was doing colonoscopy. If you took 100 patients, on average, one gastroenterologist might find a precancerous polyp in 10 of those patients. One might find a precancerous polyp in 40 of those patients. It's the equivalent of going to a lab and having your blood glucose measured, and one lab says it's 50, and another lab says it's 300, and another lab says it's 100. There's also, do those variations matter? Or maybe the main troublesome things are being identified by everyone. There's the what test to use for best uptake and accuracy. So you may have a choice within your system of your setting of a number of different tests. Is there one of those that you should choose? It's particularly relevant in colorectal cancer, where you have multiple different potential tests. The task force, I feel, kind of often focuses on questions such as like, should we do this? But often within the clinical realm, there's not only the question of should we do something, but how to be able to do it. So you may identify that, well, for example, doing surveillance for people who have polyps or a high risk lesion or perceived high risk lesion might be helpful. But then how should it be done? It should be done every 5 years. Should it be done every 10 years? And that has huge implications. About a third of people who have a colonoscopy have 1 to 2 small adenomas, 1 to 2 small precancerous polyps. And the guidelines until recently had said that should have a follow-up exam in 5 or 10 years. So it's like a third of the population having an invasive exam in 5 years versus 10 years is a tremendous question. When should follow-up testing take place? If you have a positive FIT test, does it matter if someone has that test within a week, or if they have a test within a month, or 6 months, or within a year? Everything for the patient and the healthcare system might be aligned around just that fairly narrow question of what is the disease progression and when is it safe? And then another clinically relevant one is who to identify to get testing when. Chaik had alluded to this, that there may be differences within the population on a number of different factors, both demographic as well as personal risk factors. And then even beyond that, how to identify them. So family history is a risk factor. Well, how do you identify people who have family history in a reliable and accurate way, for example? So just a real world example of this was trying to be able to find out to some extent, like, well, there's all of these things. How do you figure out kind of like where the juice is worth the squeeze? And this was a study that we had done, that Chaik and I had collaborated on looking at modifiable failures in the colon cancer screening process. So we looked at almost 2,000 people who had died from colorectal cancer and did the simple thing of looking back and saying, well, why did they die? Were they never screened, even though they were screening eligible? Were they screened at some point, but they just weren't up to date? Were they people who had been screened and they were but they were actually needing surveillance. So they were recommended to come back in 3 years and they didn't come back, and then they had a cancer in 5 years. Or did they fail to follow up after a positive test? And these types of evaluations are fascinating in terms of where to be able to gear your effort. And it turned out that, even within a setting such as Kaiser Permanente, Northern California, that has fairly high screening rates, the vast majority of people who were dying from colorectal cancer was simply because they had never been screened or they were not screening up to date. And on the flip side of it is that we spend a huge amount of effort on surveillance, but that relatively few people, that was why that they were dying. So this then can focus your questions in a lot of different ways. So then from these, the next step is really to identify those which are likely to be funded. So just very pragmatic, but there may be topics that are likely to be funded and topics that are not likely to be funded. The topic focused funding, so such as the RFAs that Paul had mentioned, those are generally felt to be the highest likelihood of success for a given question. And there are many impactful clinical questions that are difficult to fund with the standard R01 investigator-initiated mechanism. And a couple examples of these, I think, feel like some of the most impactful research that we have done, has been within Prosper, in part because it was focused on, hey, how can we fix the screening process? Those questions, and answering several of them within one R01 would be very difficult. And having an R01 only focused on one would be difficult to get funded in a general study section. The same thing with SysNet. Modeling studies can be tremendously impactful in helping making decisions. And I realize that the U.S. Preventive Service Task Force uses them extensively in being able to help inform some of the decisions, but they're also notoriously difficult to get funded in a study section. So just a couple examples where this type of focused funding is extremely interesting and helpful. And I was talking with Tracy earlier and just noting that in actuality, some of the most impactful work that we feel as our group that we've done within Prosper. And yet, we also have proposed doing that within a couple of the grand opportunity grants that had been put out about 10 years ago, which were more general mechanisms, but we're not successful in getting those same things funded within those more general mechanisms. So the support can be obtained for key questions, and just want to give an example. So we had talked about, does screening quality matter? The time to follow up, who, when to screen and pilot interventions, genetic or epidemiologic or demographic risk stratified screening, how effective are colonoscopy and FIT, decreasing surveillance. So that was partially around that question of like, doesn't look like surveillance is that important. And we had done studies that actually showed that the risk was very low. So are there ways potentially of informing decreasing? Identifying people who had high risk. So you might do risk stratified screening, but you want to find who they are. And then the evaluation of new screening tests. And so, within our group, general mechanisms of these have been funded. Several of them have been funded within the Prosper mechanisms. Those are there are 2 iterations of that, as Paul had mentioned. There is an NCI grant, as well as a grant that we are working on with a colleague in Switzerland, looking at risk stratified screening. The effectiveness of colonoscopy and FIT through a couple of R01s. These have been done in collaboration with CHIKE. The decreasing surveillance, we're starting to take part in a large NCI Forte trial, comparing 5 or 10 year follow-up for high risk, for low risk polyps, identifying people with high risk from family history as a pragmatic trial from PCORI. And then also there are industry funded ones as well, such as evaluating a new test in a serum. This is with Thierry Levin within our research group. So how do the evidence gaps from the U.S. Preventive Services Task Force serve researchers? Probably in 2 main ways. First, how to begin when you don't know where to start. You're interested in being able to start looking and be able to look for colorectal cancer research. Maybe you're a new person that's starting off. You're someone that's not clinically immersed in the field and are not familiar with the topics. They help to be able to focus what a group of experts feel are the main questions that are kind of driving where to go. The second is supporting grant development for an idea you already have. So if you had gone through some of the processes that we had talked about a few minutes ago, about being able to address those that are clinically important in kind of everyday practice, as we had talked about, then these become kind of like one piece of the puzzle. a big part of it is being able to identify and justify, quote unquote, the evidence gaps when you're putting together funding proposals. And the evidence gaps, as they're listed, they emphasize to reviewers, experts agree what is being proposed for this particular grant is in fact an important evidence gap. It's not just one investigator's idea. These evidence gaps, I won't go through them again, given that Paul and Chaik had. These align well with a lot of the research topics that I had mentioned. And I think a key part then is being able to have them also align well with ongoing funding mechanisms for answering the questions, because some of them are difficult to be able to fund through the standard R01 mechanisms as we talked about. On behalf of our teams, it really takes a village to do all of these different projects. Really a privilege to work with all of the folks that we have worked with kind of like over the years, and including the Erasmus Modeling Group that has been in collaboration on some of our Prosper grants, actually both of our Prosper grants. And I look forward to stopping and taking questions. It's on the left, my son a number of years ago. We like to bike a lot. It's a very long, hard climb. And I think kind of the end that we're at right now of actually doing the projects really in some ways is kind of the end of the long, hard climb of coming up with the ideas, of being able to get the funding and to be able to execute them. And really appreciate your thought and work about how to be able to make that process more effective. Thank you.
Okay, that's terrific. Thank you so much, Chaik, Paul, and Doug, to our panelists for some wonderful presentations. It's really inspiring to hear your large overview of a complex and very interesting landscape with a lot of evidence gaps, but also a lot of progress. You guys, all three of you mentioned some curiosity about why we chose colorectal cancer screening. I think that we perceived it to be a model problem where there was in fact some progress, so that we could take what you've learned and try to think about how that can be systematized and possibly applied to other kinds of evidence gaps. So let me look first to our committee members, and I see that people are on video. It's great that you're on video. If you would like to ask a question, let me encourage you to raise your hand using Zoom. And if the raise hand function is actually, it's in a different place if you're a participant than a host, but it's either under participants or under reactions. And if you are not able to raise your hand in Zoom, you can wave at your video and I'll look at you and moderate. So let me look at the participant list and see if anyone is raising their hand yet. And sorry, making my participant list larger. So I see Nico interested in asking a question or making a comment. Nico, why don't you go ahead?
Yeah, first of all, thank you very much for all three of your presentations. I really like this thinking about putting some frameworks in the background to support the development of questions. And my question here is mostly related to the sort of the ramp up to when to invite people for screening. So, for example, in the context of in the social context that Chaik talked about in particular, as well as I think the model that Doug presented in terms of finding deaths and where and when they occur that can guide research. You mentioned in that model primary prevention, but I think in the context of the social context, particularly issues like structural racism or healthcare coverage, education, transportation, all those kinds of structural barriers that exist. Have you thought about evidence gaps in the context of, well, let's just call it primordial prevention, to really think about those upstream barriers that may exist that keep people from even being willing to talk about an invitation to come in and be, as well as including people who are not necessarily members of a health system and therefore have much less access than others may have. Any one of you wants to address that, that'd be great.
If it's okay with Doug and Paul, I'm happy to jump in first. I mean, something near and dear to my heart, obviously. And I glossed over it, but you know, one of the things, and thanks, Doug, for highlighting that study, because that points to, I think, an enormous challenge for us, right? So there are two things that I see. The point you made about what are the upstream factors, and to that point, I briefly say that the U.S. Preventive Services Task Force has a work group on race and racism. But even prior to that, we have a work group on social determinants of health that Karina, who is on the call, incoming chair when Alex term runs out, is leading. And so we are looking at those factors, and to the extent that we can build them into an evidence development process and to inform exactly the question you raised. On a very basic level, some of the challenges are, and I sort of alluded to this, some of the challenges are, what really is the evidence we have about the differential impact? Because sometimes we don't even know as well as we need to know how the risk is distributed in the population differentially across different groups. And of course, the measurements of how that risk can be characterized can be very challenging, because we characterize things by race or by other factors that may not be applicable to the context of patients. So that is a huge challenge in itself. But the task force, if I may, is taking the view that we have to look at those factors, and to the extent possible, how do we integrate them into the recommendation development process in such a way that we can begin to promote, hopefully with a lot of different partners, because we have a small slice of this challenge, right? Begin to promote equity in both the way recommendations are crafted, but also in the implementation of recommendations, both sort of at least looking at the upstream factors and then the recommendation itself. And then if you think about it downstream from recommendations, how would they be implemented by primary care clinicians? Because that's sort of where I believe that the risk is higher for the same factors that we talked about, right? But the recommendations may not capture risk as well in the risk assessment process. And then when you deliver these recommendations in practice, you know, and sadly, I hate to say, racism kicks in some form. Maybe we know it, but we don't know it, but it kicks in some form in such a way that that interaction, we know that, for instance, colorectal, we've done studies to show that the provider recommendation of screening is a very powerful effect on screening uptake. Ability to address structural barriers is a very powerful way to provide screening to people. And if you provide screening, and Doug's slides and Paul mentioned this as well, I think it's a disservice. I don't want to get emotional. It's a disservice when we do that and don't provide access to diagnostic testing. I see that happen so many times. And I think, you know, it's not in your purview necessarily, but I think that's an area where I see it's a disservice that we do to people when we say we're going to give you a FET, but there's no way you're going to get a colonoscopy. So you saw some of those elements in my slide. It's a capacity issue. And if you think about it, Alaskan Natives have some of the highest rates of colorectal cancer in this country. And it's not because, in my view, that they're genetically predisposed. It's because they don't have access, and risk factors are through the roof. And so I think it's really a challenge. And you know, of course, Paul knows this and Doug knows this. PROSPER is great, but it's not enough, right? It doesn't really cover the landscape of places in which this can be done. There are other programs like Access and other things to address this. But again, the task force does this slice of it. We need to be able to have people like Paul who are handling this other aspect of it, and maybe community guide who is sort of handling this downstream part implementation. But all of that needs to come together. But the task force tries to highlight all of that matrix, because by doing so, we call attention to the importance of all those factors in the, what I refer to as evidentiary chain, from risk factors to treatment, because without that, you can't get the benefits. It's a long answer to your question, but you hit on a nerve.
Let's look to Paul and then to Doug if you have, you know, perspectives from the sponsors and researchers' point of view.
And I couldn't have said that nearly as eloquently as Chaik did, so I'm glad you took it first, Chaik. But I think I'll just add fairly simply.
And Paul, your audio is a little bit soft. Can you reposition?
Let me see if sorry, my mic, is that better?
That's better.
Okay, thanks. Sorry about that. I think, I'll just add from the NCI perspective that I think one thing that really, what was a pretty awful year last year hastened was kind of an evolution in thinking, I think in the research community as a whole, but I think it's now we're seeing represented in the kind of funding announcements that are coming out in thinking about health disparities and health equity as kind of a risk factor. Like we're kind of demonstrating that certain groups don't get screened at higher rates or don't receive a follow-up after a positive screening exam, to something we want to intervene on. And, just within the last couple of days, we had an announcement coming out, and this is an announcement that there will be an announcement, I guess, but there's an intent to be releasing a funding opportunity announcement by NCI that's focused specifically on structural racism. We also have it, we've within my program, the Healthcare Delivery Research Program, now have a structural racism focused work group that's looking towards as we're going through our own strategic planning process. So I do think, right, it's kind of something we've talked about and have recognized as a problem for years. And I think we've again, we've reached a place in our country that the movement to act is getting louder and louder. And I look at that as a silver lining.
Doug, any follow-up thoughts?
The question that you raised, I think it kind of is key to a lot of the approaches that we discussed. If you take it from the standpoint kind of along the lines of what we're saying, like even within a relatively high performing system, the main for death is people not getting screened. It allows you to be able to focus the research on, okay, well then, are there differences among people who are not getting screened? Is it mainly people who are from particular demographic backgrounds? Is it mainly people who are, elderly or people who are ill? And then it's also the question of the research that goes into beyond that. Well, then why? So like an example was, and this was just taken from an operational perspective, or I should say funding or projects perspective, was that within our group, it was noticed that Hispanics had a slightly somewhat lower screening rate. So the question was, well, why? And so there were focus groups that were put together. There was actually an intensive evaluation of like why that was, and the feeling was that it was some of the the messaging that was around it and the outreach was not as culturally appropriate for the different groups, and so new materials were created and then which were more effective. And I think that's an example, of being able to say, well, the problem is screening. Okay, now let's look at it more closely. Who's not getting screened? Okay, now like why are they not getting screened? And those are all research questions. Those are all, but they start at one place and then they end at another. And then ultimately the end, can be some type of a trial where you're evaluating different types of methods to be able to address the question. The same thing for follow-up of screening, which again, we found about 10% of the people, which is like pretty remarkable that, not very many people are positive, but 10% of the people who were dying, it was because of failures to follow up. So I think those methods allow you to be able to focus on where the main problems are. And then the other thing, which we've built into our own research, but I think is just the aspect of being able to do it systematically, is just saying, okay, for everything that we do, we're going to be able to evaluate whether there's heterogeneity of effect or association, across demographic groups. Not just adjusting, but actually looking for differences, because then that also then kind of drives the next steps of research or intervention if you find things and understand them. And I'm happy to give examples of that as well.
Okay, excellent. I'm keeping an eye on the time. We have about 30 minutes, and I want to make sure that the committee members have a chance to ask questions that they want to learn about. I'm going to look at Kathy Bradley, who I know has had her hand up for a while, and I think Bob Wallace might have been waving as well. I know that Alex, Chris, and Sue Curry have their hands up, and so let me bring in a couple of committee members, and then we'll come to you. Kathy, go ahead.
Thanks, Tracy. First, I want to thank all the presenters for the excellent presentations. And I also need to just apologize in case I keep getting a message saying my internet is unstable. So just in case I freeze. What struck me, this is more of a process question, but what struck me in the presentations, especially around Prosper and SysNet, is the infrastructure underneath those very large operations and the investment that it takes from the funding agency to build the infrastructure out. So Prosper was built on CRN, and being in an area that already has considerable infrastructure in place, the virtual data warehouse, the researchers all already there. And SysNet is an amazing modeling group of different from different universities and cancer centers, but the NCI has put a lot of infrastructure in place in order to make that work. And I know Rocky invests a lot of his own time there. And in Paul's presentation, he said investigator initiated grants are welcome, but it would be very hard, it seems like, for the individual investigator to jump into this, given that from what I've heard, it sounds like to really address evidence gaps, you need this big infrastructure investment, possibly from the funding agencies that's interested in these evidence gaps. And I just would like to hear some comment on that.
Yeah, maybe we should look to Paul first on this one. Paul?
Yeah, I knew that would come to me first. Yeah, I mean, I think it's like what you say, Kathy, is it's a real challenge. I mean, I think, you know, I've been the person advocating for funding for these large initiatives, and you know, they're expensive, and they come at the kind in a, you know, and I should have prefaced all of this with the views I'm now expressing are my own, not necessarily those of NCI, but you know, every time we fund an initiative that costs $10 million a year, that's a lot of R1s that we don't have funding available for. And it is, so, you know, and that's the currency, right? That's the currency by which Congress will look at us and say, okay, this good, and NIH is doing a good job. So, you know, I felt at times the frustration of, you know, kind of advocating for that kind of funding. That said, I think, you know, when we do go, you know, when we address or when we identify a specific area that, as you know, as Doug, you know, so very well said, like it's really hard to do this kind of work under, you know, and a standard side for sure, R1. That, you know, I will say that we've been quite successful in saying, you know, in going to our leadership and getting these kinds of initiatives funded. I think this is actually a good time to also say that, you know, when we're talking about kind of the haves and the have-nots, right, we're selecting a small number of groups, right, even with the price tag it comes with. And there's a lot of other health systems not represented, and Prosper, I think I'll give as a good example, right? We are looking for our keys under the lamppost, right? We're looking at people who have access to healthcare, and who are engaged in some way, by and large, with a healthcare system. But you know, it became a measurement problem to say, right, we felt like we could track patients through the screening process, and because our you know, we have to kind of look at all the downstream events from the screen. If somebody's lost a follow-up, then we can't do that. So, you know, if we identify, you know, major problems within, you know, kind of those who should be in the best, you know, have the best continuity of care to be able to progress through the screening process, you know, it's clearly there are bigger problems elsewhere. And you know, so you know, we kind of have to be targeted in what we build as these kind of larger infrastructures. And I think, you know, the other thing we've been trying to do increasingly, and is a focus of the second funding cycle of Prosper 2, is we've had a you know, we've kind of revamped totally what our data sharing processes look like, as a way to kind of really be able to let more people at the table to leverage these infrastructures to, you know, to be able to address questions kind of outside of those initially proposed by the applicants. So it's a tough. I mean, there's no easy solution to this, but we're kind of trying to do the best we can again to kind of recognize where we need to build these big infrastructures, do what we can with them, and then go from there.
Great. Let me ask a very brief follow-up question before we go to the next person with the question on the committee. So, Paul, you alluded to the idea that Congress will evaluate you maybe more based on your R1 funding than these large infrastructure grants. Can you tell us a little bit more about that? Like, do you get less credit for?
I mean, I think it probably boils down to kind of, infrastructure isn't sexy, right? Like it's kind of, and what we do, it's one grant, right? Like it's one big grant, but it's one grant. So I think, what we end up doing again was we kind of assemble, this is part of kind of what I'm doing and others are doing when we're advocating for these kinds of networks. We really try to highlight what we can do in Prosper or SysNet that we couldn't do in a different way. But it's still, it is something that requires a lot of effort on our part to kind of, educate and kind of assemble the product that we have that we wouldn't otherwise have.
Okay. That's great. Thank you so much. Alex, it sounds like you have a comment and not necessarily a question, but it might be helpful to the committee. Is that?
Yeah, and I apologize. I know you had called specifically for committee members, so I apologize for raising my hand. But and I've really enjoyed listening to the discussion and everything. But I was struck by one of the challenges that I sort of heard coming out in the discussion that we regularly face on the task force, and it relates to scope of well, what is within scope and what is not within the scope of the task force. And I mean, there's no question that making sure that people get a recommended service is important. If people don't get a service, it's not going to improve health and we won't have the benefits of prevention. But the task force has, I think, 82 topics, 138 letter grades, and just an enormous scope as it is. So we're regularly talking about scope. And I think the analogy you talked about, Doug, I think is a great one, which is polyps. And when you find polyps, because 1 in 3 people have a polyp. So it really does become part of that pathway of prevention, you can argue. But on the other hand, we've been pretty specific in saying we're not about making recommendations in disease management of conditions, follow up on tests, how do you deal with things. In many cases, it's a different framework and level of evidence that you would look at. And polyps is a tricky one because you could argue with it so common that might be more of the norm, and maybe sometime that would be included in the future. But then on the other hand, you're going to have all these groups starting to petition and say, well, review our drug for treatment of this or our intervention for treatment of that. So there's this slippery slope too. And, just to be conscious for the group with the task force linked to the Affordable Care Act and coverage, that's an important topic to be thinking about. So I say that in the context that just for I encourage the National Academy Work Group to be thinking about scope, sort of what does the task force define as scope? But then also, there is some kind of evolution in how that is. We issued a piece around addressing equity and structural racism. We do want to look at that. We do look at uptake of preventive services in some of the background of our systematic reviews, and there's opportunities to comments about gaps. But I do want to be careful that we don't ask the clinical preventive services task force to do more than they have to. There's a lot to do, but there are some needs for some boundaries with scope.
Great. Yes. Thank you so much, Alex. And I think that it's important to recognize that we don't expect the task force to solve every problem within clinical prevention. So that's very helpful perspective. So I think Bob had tried to wave, and then we have Venkat. Is that, were you trying to ask a question earlier, Bob? Or shall we go to Venkat? let's go to Venkat, and then yeah, we'll keep going, and we can loop back around to Bob.
Yeah, I mean, again, this is a broader question. As you think about it, many of the screening or preventive services questions really are cross-cutting and are common across many conditions, whether you're thinking of colorectal cancer screening or breast cancer screening or diabetes screening or screening for any condition. And secondly, we also spoke about the challenges of these infrastructure grants that are large and flexible. So is there an opportunity here to address both through trans NIH mechanisms where several institutes participate to address questions that are of common value across conditions, whether it's structural racism or it's uptake or whatever it is, and plus also provide meaningful large infrastructure for flexible ways of addressing specific questions of interest to respective ICs. So I think I'm arguing for a hybrid model where there is a trans NIH collaboration, plus within it also individual institute flexibility. What I'm finding is when I think about it, is a lot of fragmentation and also a lot of smaller studies are not able to address fundamental questions, whether it's about the underlying dynamics of screening or about specific screening for specific conditions.
Great. That seems to be another question for Paul first.
Oh, geez, I don't know how to answer that one. I mean, I think, probably there are more opportunities to do things trans NIH than we do. There certainly are, initiatives that are trans NIH. It's things that have, I've been in it, Kathy mentioned the Cancer Research Network and the umbrella organization, the HMO Research Network. There have been kind of, and this is kind of a historical example, kind of some efforts to, kind of to do things across different institutes and kind of recognize that the infrastructure was built from the firstly the CRN, but a lot of other, kind of disease-specific networks kind of grew out of that. And I guess you don't have to convince me. I think it's something that I think I probably don't have a good answer for you today, but something that you're certainly making me think about how to do more of that, because it really is, again, it becomes to some degree the same issue of, what do you target? Like how do you make the decision to say, well, this is something I want to do with other institutes versus something that this is something I want to focus specifically on cancer. And so, for the same reasons we're making choices about what large initiatives to propose, that's kind of the macro version of that. What then is so important that we not only are doing a large initiative, we also want to do it across, across topics and multiple different groups. I mean, I think, I'll give another example. At least from my division, right? Like, there are large cohorts that are supported through NCI that certainly have the ability to address lots of different questions. So, it exists, it's there. It's probably something that, you can't do for everything, but probably we could do more of.
Great, thank you so much. Did Doug or Chaik have an addendum to what Paul just said?
I wanted to follow up to that. I mean, especially in looking at what the evidence gaps were around colorectal cancer, I don't know that all of these requires a huge infrastructure heavy initiative. I think it's the difference in some ways between a program announcement and an RFA. Like whether or not you're just saying, we're interested in this area, and if you submit something, it's going to be put in the general pool and, evaluated along with the mouse model for pancreatic cancer, or is there kind of like a dedicated funding and we're going to fund 2 projects in this area? I mean, if you want to be able to say, one of the things around, CT colonography, what's the effects on mortality, and what are the extra colonic findings, and you could have a focused evaluation or announcement just around that. I mean, you can have there are several of these that I think don't require creating huge infrastructures, don't require 5 centers pooling data with the additional costs of that. So I think there are opportunities, but it's just a matter of the question. It's just a philosophical one, of whether or not aligning groups that really come together and spend a huge amount of time on creating questions, such as the U.S. Preventive Services Task Force, and then not expecting them to do anything with those, not like becoming the funders or not becoming all these, but whether or not those then become aligned with funding opportunities and then opportunities for researchers to answer those questions through those funding opportunities in a dedicated way. I mean, it seems like that's the main philosophical question.
Very good. All right. So let me actually look at Bob Wallace and just check in about whether you did have a question, and then we'll go to Sue Curry. Bob?
Yeah, thank you. Thanks to the speakers. These are really thoughtful and interesting comments. I just wanted to get back maybe a little bit to medicine, not to demean the social and behavioral aspects of all of this, which I think are pretty important. But let me just ask you a little bit about in the models, in the studies, in primary care practice, where does all the comorbidity fit? If I had to, put it that way, of course there are, if you go through the ICD, most people are pretty well, but there are thousands of diseases out there. But I'm also thinking about mental health problems. 20% of a population has one serious and probably others in their lifetime. There's an awful lot of substance use. So when you try to figure in the behaviors and as well as the interpretation of a given screening modality, there seems to be so much in the way that really doesn't count that much or gets considered. And in fact, in certain ways, because of randomized trials, a lot of these things get put aside because they're randomized. And I'm just wondering about, important medical problems, some of which are physical, for lack of a better term, but a lot of them are mental and emotional and behavioral. And how does that fit into the models and into the programs?
Wow, that's a tough one. Let's look at it.
I can try to take a stab at it if you like. And I think hearkening back to what Alex said earlier and what we discussed earlier, if we take sort of the role of the task force as making a recommendation for clinical preventive service, and that recommendation is intended in the case of colorectal cancer, say for those who are 50 to 75 with an A recommendation, or if the draft recommendation gets confirmed once it's published, is 45 to 75, then everyone, at least in theory, within that age bracket should be recommended for screening. And the ideal is that everyone in that age bracket who is eligible for screening should be recommended for screening. So you saw that graph that I doodled, and it sort of said, where do you start and where do you stop? But within that is moderating factors that may change in terms of who may be a good candidate for screening. So if you have terminal cancer, sort of an offside example, it may not make sense if your life expectancy is so short to do a colonoscopy for screening, because it's about the harms and the benefits. And so the benefits of screening accrue in the future, the risks are immediate. And I think that's one way to kind of think about it. But there's no doubt in my mind that mental health has an impact on people's ability to receive just about any care and the outcomes of care. And so the task force per se is not prescriptive of sort of what providers do. What I think what Paul and Doug are saying is that if the recommendations, we hope we will deliver it with fidelity to everybody who is eligible to receive them. And that work is part of the implementation process of making sure. And a ton of work, from my knowledge, has been done on the issue of comorbidity. I'm not sure, I know of some work in the area of mental health. But I think, Bob, is an enormously important question that maybe is understudied. maybe under leveraged in the way we deliver care. But from the task force perspective, we have an interest, obviously, because if people is not getting the recommended service, then it's not really achieving its purpose.
I'm actually going to suggest that we move to Sue Curry, because I see Karina Davidson has her hand up as well. And that actually, we have about 10 more minutes that may finish our conversation, unless we have time to squeeze in one more comment. So let's look to Sue, and Sue, go ahead.
Great. Well, thank you. I want to thank the speakers, and I really want to thank the committee. I know how hard this kind of work is, and I think it's made even more challenging when you can't be in the same room at least a few times to hash things out. I'm going to do a true confessions here. I'm sitting here with a tremendous amount of frustration because I haven't heard a conversation about taxonomy. I've heard a conversation about colorectal cancer screening, and I think it's really important that we think about what it is that this committee is trying to achieve. Having been, again, full disclosure, the person who drafted the statement of task quite a long time ago. I think that, and I'll have some comments later about it, but what I thought it would be helpful to hear, if we can briefly, is especially from the NIH perspective, have you looked at the recommendations? Has there been some frustration in how the gaps are described? Not just for colorectal cancer screening, but you could unpack that one as well. I mean, I would say if there's a recommendation that probably is the least in need of a taxonomy, it's colorectal cancer screening, because it's been very clear, it's been reviewed, it's been re-reviewed, and the gaps are there, the infrastructure is there. So how does this deep dive into colorectal cancer screening, which is incredibly important, and these questions are so valid and important for the health of the public, but I'm not sure I can draw a line from this conversation to a conversation about a taxonomy of research gaps.
So, I'll take a pass at this, Sue, and I'd love to hear also from the panelists on this. I think that what we're trying to find in this conversation are the topics, the concepts, the language by which a funder like Paul is looking at a task force statement and then thinking about how to put that out to a researcher. So kind of trying to draw that line from what the task force is trying to say about here's some evidence gaps, and syncing it up with the kinds of attributes and priorities that a funder at an NIH institute or any other large funding agency would have in order to try to translate that into instructions for what a researcher would do. We did not want to start in an area that had a dearth of successes because we wanted to hear how in an area where things actually do seem to be synced up between the task force and the funder and the researchers involved, how they make those connections. And it would actually be helpful to hear from you, and I know that we will hear from you in the next session, and from Alex and from Karen, about where the existing taxonomies are, falling short or not helping put that together. But we wanted to get the big picture of, what are people doing in practice, in a sense. But let me look at Paul and Chaik, and I'm specifically interested in when the task force thinks about articulating an evidence gap. Does it go back to PCOTS or some other taxonomy, or PCOTS obviously does not cover implementation, it does not cover equity. These are some of the observations that have emerged early in the conversations. To what extent do you think about a systematic way of using concepts to relay to the researchers and the sponsors what the priorities actually are.
And we have enough of my colleagues, so if I get in trouble, I'm sure they'll jump in. Karina is there as well. I see Karina's space there as well. You know, the evidence gap process emerges as part of review, and what I presented to you highlighted, for instance, PCOTS as one of the frameworks that obviously guides the review of the evidence, and the analytic framework. And so when I look at the key questions that I ask for each of those analytic frameworks that I use for each topic, they naturally lead to whether or not the evidence is adequate for the decision, for the recommendations to be made. And if it is not, then it generates its own question. Even when the evidence is seemingly adequate, it may still have gaps, either in the inclusiveness of the population or other areas. So I think the PCOTS framework, I find it very attractive as a way to look at it. I know years back, and Alex will present later, there was an exercise to develop that taxonomy, and Alex can talk, eloquently about it. And I think that, force at least a small group of Alex and Mark and others to think about how do we kind of put this in some framework to think about the evidence identification process. But I personally find the PCOT to be very attractive. I also find the analytic framework to be attractive as a way to sort of think about where the gaps are along that evidentiary chain.
That is helpful. Paul, anything to add here?
Yeah, I mean, I guess one thing, I'm struck by the morning, and maybe it's not an accident since Shaik and Doug and I have all worked together on many research projects, is kind of how well aligned kind of the things we're asking about are. And, again, maybe that's a function of where colorectal cancer screening is. And there are obviously bigger challenges to tackle elsewhere. I think, I will say that when I look at evidence gaps as reported by the task force, I think I would frame it kind of similarly to what Doug says. I'm a consumer of this is a source of information, and it may be to the extent that what I'm trying to accomplish is aligned. It gives me, it's a source of ideas, and it's a source of something to cite when you're writing about it. And I think, for me, the exciting part of this meeting is to really think about kind of formalizing that a bit more. We had back in, the last time that our Prosper Network met together in person in October of 2019, we actually had a guest from the USPSTF come and talk to us about how can we work together? How can we think about this together? And I think, to me, the dialogue between them, the taxonomy is important to have the words to use to discuss it. But I think also then the next step, right, is to actually get the different bodies talking to each other.
That's great. Doug, anything to add briefly? Okay.
No, I mean, I don't really have anything to add. I think that was something well.
Very good. So, I think that we'll take our last question or comment from Karina Davidson. Welcome, Karina.
Thank you, everyone, and thank you for spending your time and energy on such a difficult, complex topic. I'm going to propose something radical back to this group. And so I'm going in a very different direction on a very different topic, so bear with me for a moment. There was a recent condemnation of the way the entire nation managed to do COVID-19 treatment trials in an editorial published recently in JAMA. We had individual investigators fighting with each other to compete to get patients to have their own program of research, their own personal pet project, get funded. We had what was at least offered by the editorialists, a remarkable amount of noise and energy that ended with very little progress coming out of our scientific enterprise for advancing actual treatment through randomized controlled trials for the management of this pandemic. This was contrasted with the UK, where NICE pays for both the clinical care and for the trials. The infrastructure was set up and they managed to answer some questions definitively and so could move on from having ongoing controversy. I think about the gaps that we have as a task force in the evidence that we need, and those gaps result from individual investigators pushing their own agendas, politically thinking through, as Paul so well noted, what manages to get through review, what their colleagues will allow them to do, what fits in a 5-year, 500K or 250K mechanism. And we cobble together all of that evidence and then say back to everyone, here are the hundreds and thousands of gaps that occur from this patchwork of designs, questions, problems, aspects of studies that happened because we can't answer definitively our KQ1 question. If we had trials that answered our KQ1 question, we don't need a taxonomy of gaps. You know, as you said earlier, we might end up saying, oh, of these 40,000 people, we didn't have enough with comorbidities. We'd like a subgroup later to work on those who have more than 5 comorbidities. Oh, we now see an implementation of the recommendation out of that KQ1 trial, but I think all of us would much more transparently look at the gaps that happened if we weren't constantly doing this complex process. So I'm saying if we moved upstream to the sort of very larger questions, I know you might say this committee can't do that. We have to look at what comes downstream and the piecemeal gaps that are left from the thousands of studies that our EPCs review and think about. And each and every time in that patchwork, we try to use a PCOX, as Chaik said, or to use our analytic framework, as you're going to hear later, to think through where all the pieces are. But we have a larger problem, and I just wanted to bring that up to this committee. Thank you.
Yeah, I think that's a helpful comment, Karina. This committee does think a lot about the scope of the committee as relates to the scope of the task force and the scope of the the work before us in general. I will just say that our statement of task includes several different activities, including the taxonomy and figuring out where the taxonomy fits in. Shall it try to address broader questions that seem to be, fall before the task force would get involved, so such as access to screening or downstream from the immediate prevention question is really actually one of the challenges before us. So thank you very much. It's we need to form a useful taxonomy. We need to know where that fits in and what we want to highlight through that taxonomy, I think. Okay, so you have your hand up. Did you want to make one last comment? I know we're into our break time, but.
I'll get there. I'm going to have some airtime, so I took my hand down. Thanks.
Okay, that sounds great. And actually, so you and I can confer briefly during the break if you'd like, because I know you have a session coming up as well. So why don't we do this? Let's take 5 minutes, maybe even let's take 7 minutes. I see that my clock says 9:38, so yours, most of yours probably says 12:38. Why don't we reconvene at 45 after the hour and give ourselves a break, and then we'll go into the taxonomy group next. That's okay.
I'm here.
Okay, excellent. Committee members back. That's great. Okay, terrific. Why don't we go ahead and get going again? Our second panel, it includes Drs. Alex Christ, Karen Robinson, and Sue Curry. And they're going to discuss how taxonomy can be of use to researchers and funders. They also will discuss previous attempts at characterizing evidence gaps by the task force and by others. And after their presentations, I'll moderate a discussion between them, open up to the committee first for comments and questions, and then also invite other members of the task force and audience members to join the discussion. I'm going to look to our panelists to introduce themselves, starting with Alex.
I'm Alex Christ. I'm a family physician at Virginia Commonwealth University and the current chair of the U.S. Preventive Services Task Force.
Thank you so much for being with us, Alex. Karen Robinson.
Hi, everyone. I'm Karen Robinson. I'm a professor of medicine, epidemiology, and health policy management at Johns Hopkins, where I also direct the EPC.
Thank you so much for being with us. And Sue Curry.
Hi, Sue Curry. I'm emeritus dean and professor at the College of Public Health at the University of Iowa. I served on the task force for 10 years, including serving as vice chair for 2 and chair for 1 of those 10 years. And I've also been a special advisor or scientific consultant to the Office of Disease Prevention at NIH, specifically related to this topic.
Great, thank you so much. So let's look to Alex first, and we're very interested in what you have to present to us.
Great. Let me bring up my screen here, and I have a couple slides to make sure that I cover what I want to cover. And I just want to start by thanking this committee. I mean, this is not a small task here to try and describe the research gap of the U.S. Preventive Services Task Force recommendations and to create a taxonomy to try and help close those gaps and then to test it and implement it. I think this is just great. It's actually really needed, and I think the timing is perfect. Like Chaik, I'm going to put up the same disclosure. So, while I'm the chair, I'm going to kind of talk a little bit about some of my thoughts, not just the task force thoughts, but I'm happy to share the task force perspective as best as I can. And a number of members are on, and they'll keep me on track as well. So this is an important topic just because we always are going to have gaps. And, we're not just talking about the I statements, and a couple people have said this. And I'm going to show some gaps at the end of these slides. And I think that kind of highlights this. And I know that committee members have seen these taxonomy slides that Chaik and myself and a number of members from the U.S. Preventive Services Task Force and the Canadian Task Force presented at this NAPCRG, the North American Primary Care Research Group conference. So I'm going to show a couple of those slides, but it's because I want to talk about what we are trying to do and what happened with them more than just reading what's on those. And the context of this is that back in 2017, the task force was writing these reports to Congress to try and close the evidence gaps. And I was kind of shocked that people didn't know about them. And so NAPCRG, if you don't know, is a primary care research group. It's probably one of the larger ones, particularly that's family medicine oriented. And I really wanted researchers in this group to know about this, to be able to go to these congressional reports and to look at the evidence gap sections of the task force recommendations and use that to guide their research, both to help them as researchers, but also to close the gap and to move the field forward. And so there, over a series of 3 years, we did this workshop every year. And there are probably about 10 of us who ran it, of task force members from both the US and Canada. And I'm going to cite some of Karen's work because we cited it. Apparently, I have to admit someone. Apparently, we cited Karen's work to kind of kick off this work group. She talked about common reasons for evidence gaps: insufficient and precise information, biased information, inconsistency or unknown consistency, and not the right information. And she has a framework that she'll talk about and may talk about differently than I thought about it, or we thought about it in the work group. But we had thought about this PICOS typology that's really looking at these different questions that the task force is looking at when we're making recommendations. So, is it the right population? Is it the right intervention? Do we have good comparison groups? Do we have good outcomes? Is this setting relevant to primary care and to preventive services? I mean, these are all the things that we're asking ourselves as we're looking at the evidence for each step of the way. And it's a good way of sort of thinking about the internal validity of the studies. Like, are these the right studies as a body to answer the questions that we're trying to answer about whether this preventive service works? So this is an important kind of way of thinking here. We had another way of thinking, and in disclosure, I'm an implementation scientist. It's much more about how do you put recommendations and things into practice. And so Mark Ebel, who talked about the taxonomy in our workshop, called this the CRISP taxonomy around dissemination and implementation. It's not any further than this one slide has said. It's got no other greater penetrance than that. But we are focusing a little in our discussion about these other gaps. And I think we talked about these in the first session about, how do you implement, put things into practice, things like the interval, intensity, essential elements, can it be modified? We thought about dissemination. How do you get it to work in different settings and other things? How do you reduce disparities? How do you make sure it's sustainable? And we thought about population gaps. Now, when we think about D&I, this is an area going back to where I was sort of raising the scope questions. And so we have a defined scope that we're looking at. And one of the things I like to say is that I really view our job as making sure that clinicians and patients know the state of the science around preventive services. So what do we know? What do we not know? They're equally important. And we have a dissemination and implementation work group within the task force, but this is an area that we struggle a little because some of dissemination and some of implementation is outside of our scope, but some of it is. Like, if we're going to describe the intervention and what needs to be done to make it work, those are key elements for us to communicate what this preventive service is to clinicians so that they can put it into practice. And this slide, I think, gets at something, if you link it to what we talked about before, which is sort of the thinking a little bit about the life cycle of the evidence. So we've got some recommendations that are pure I's, and we really don't know what they are. And I think a gap taxonomy would be different for those. That would probably be much more grounded in that PICOT's framework, where you're thinking about what are the groups and the studies and comparisons and things you need. And then you've got recommendations where there's some elements that we know we're recommending doing it, but there's still a lot of gaps, and I'll show you a couple of those. And then we have other recommendations like smoking cessation counseling. Well, they're pretty well established, but there's still a ton of gaps, and they might be more on that D&I kind of life cycle of the evidence. So that might be important in thinking about taxonomy. And then Mark Ebel had what he called his inadequacy taxonomy. This was kind of delving a little bit more into the lens that we're taking as we're looking at these studies as a group. And it probably comes up a little bit more in the I areas, but also when we're calling out specifics. It has to do with numbers and size of studies. So sometimes we have an I because there's a ton of studies, but they're just not well designed, and they're not the right studies. It's the duration, it's the methods that the studies used and the biases these messaging methods introduced. The intervention might not be exactly correct. The populations might not be exactly what we need. The settings might not be. That's a common thing, the settings. So we'll frequently in the treatment trials see things being done in groups of individuals who have symptoms, which is very different than what the task force is doing. So let me just share what happened at the workshop, just so you know, among these primary care researchers, a lot of interest in the D&I gaps, a lot of talk around that. There was talk about how practice-based research networks could close the gaps and trying to bring all these groups together and build this infrastructure that was talked about. Not a whole lot happened with that, just there's not great funding. And there was discussion about typology. There was a lot of interest, a lot of academic interest in it, and it was a big source of discussion, which we can share in our discussion point here. But this group didn't really address it, who attended this research or these workshops. But this group, meaning you all, you're exactly the right group to do this. So I'm very happy about that. Chaik talked about how the task force does this. And I mean, we don't have a specific taxonomy. We don't have a specific framework. We are regularly talking about sort of how do we be consistent in what we do. And so that's why I say the timing is perfect here. We're very much driven by the evidence. So this is our analytic framework, as people talked about. Karina was making a passionate plea for, more evidence for that KQ1, the direct evidence, the big trials like your breast and colon cancer trials that randomize people to be screened or not. But there are all these individual key questions, and actually for some recommendations, there's a very specific gap, and we could fill that very specific gap and maybe very quickly or more quickly get to the answer. So there's a lot of variation in the needs. A lot of the gaps that we're identifying, they are framed by our key questions and contextual questions, and they could benefit from a common language and a common system to define what is and isn't included. If you haven't looked at our research plans, every recommendation starts out with a research plan, and it's got that framework, but then we actually put in a PICOTS table. And this is useful when we often create this, the EPCs use it to find the evidence, but this could be used to go back and look after we're done with the recommendations to say, okay, when we go and we look at this PICOTS table, what happened in terms of gaps with population setting, intervention, comparisons? Where are we missing things? And I'm not sure we always go back and do that, although we do try. I want to show you a couple recommendations and just give you examples of what we're dealing with, okay? And you'll notice all the recommendations I picked are letter grades, so I didn't pick any that is just an I statement. So some gaps in what's needed to close those can be very specific. So here for AAA screening, we are able to call out, we need appropriately powered RCTs on women with risk factors to be able to know whether this is going to be beneficial for women. And I know there's lots of calls for us to be specific in the evidence that we need. And here's an example of where we're able to do that. Other gaps are completely obvious, but how to close them is not. So this is prostate cancer screening. And the clear gap for this is in Black men. And the current evidence, the big trial, the PLCO, which had 82,000 participants in it, only included 4,000 Black men in it. So we're not able to make a different recommendation. But the reason that how to close this isn't clear is because it took us 20 years to get that data. So we can't say we want a big RCT that's going to answer this. Yes, we do, but that'll help us 20 years from now. And the science will probably be way past that. Other gaps are about groups. So this is Sti Counseling. And we really called out some groups that are at higher risk, or that we might think about higher prevalences and that we need a little bit more specific evidence. And you can see some groups that we called out, but there's always this challenge of, well, who do you highlight and who do you call out versus not? Because there's an infinite number of groups we could be thinking about, but there is some type of a scope we want to say. And then I'm going to end with this. This is on healthful diet and exercise. It's also another one of these recommendations that I think are pretty well established. But this is about a potential future direction. So beyond just the screening and counseling for healthy diet and exercise, this concept of sedentary lifestyle got raised up. And so we're calling out for more evidence to say, well, let's think of the next phase in sedentary lifestyle and what would an intervention around this be and what would evidence around this need to be. But once again, when do you call out the next steps, the next iterations, how you change interventions, how you improve things, and when do you not call these out? And I think that's some things that this taxonomy could really help us in moving forward as well. So I'll stop here, and I appreciate the time to talk.
Okay, great, thank you for that really helpful overview, Alex. Let's go to Sue, and we'll just switch gears. Oh, I'm sorry, Kathleen is saying it's actually Karen next. Sorry about that. Go ahead, Karen. And
Karen, I think you're on mute.
And sorry, I have two screens going, and so when I shared screen, it popped up on another monitor, so I apologize for that. Thank you for the opportunity to speak with you. And I appreciate that the panel has a difficult task and are trying to get information from a variety of sources, and I appreciate that you think it's worthwhile to listen to me. as you see, I put glasses on, so I may age myself that way. I want to also, by way of introduction, age myself by saying I've been involved with the EPC program since 1997, when it started. And I've also been working with Cochrane since 1995, wearing a variety of hats as author, researcher, and editor. And so I wanted to talk, to start with, a little bit about my motivation for working to create, develop more systematic methods for identifying evidence gaps. And really there are, for me, two kind of general motivations. One is what I think many of us have experienced, the frustration of the more research is needed, the insufficiency of insufficient evidence. So that's certainly one motivation. The other motivation is around the idea of redundant trials. So trials that are causing waste that maybe did not need to be done, and trials that are putting people at risk. And as an example, here's a recent example from a postdoc that was working with me. Along the top, what you see are the number of patients that were randomized to placebo control in statin trials, and this was in China. So these were trials of statin versus placebo. The red arrow indicates when the guideline in China, two guidelines actually in China were published saying statins work, we know the evidence they work. So what you see is all the trials after we knew, quote unquote, knew the answer. So 2000, what we would suggest are redundant trials, randomizing 90,000 patients to receive placebo or no treatment. And further, Yongxi, the postdoc, estimated that more than 4,000 events, MACEs, could have been avoided, and including 500 deaths. So the question for me and others like me are, how did these studies get funded, and how did they get by the Research Ethics Board? So this meta research, and I did a similar sort of study for my dissertation, prompted development of evidence-based research. And I define evidence-based research as using evidence to inform research so that it addresses questions that matter in a valid, efficient, and accessible manner. So to me, it's all around using evidence to inform our decision-making, not just about what prevention we need to implement, not what treatment we need to perhaps take up or provide, but we should be using evidence to inform our research as well. This started the Evidence-Based Research Network in 2014 in Bergen, and there's also now a EU-funded cost action called EVBRES. And so as part of evidence-based research, we're promoting the idea that there should be an explicit consideration of evidence at really 3 points. Before the study, to justify the study, identify answerable and worthwhile questions. During the design of the study, to make sure that the study is designed in the most informative manner. And then at the end of the study, to place the results of the new study within the context of what was already known. Obviously, for this talk, we're focusing on those first 2 points. And I think it's important that it's not just the first point, not just about questions, but about the design, most effective design for the studies to answer those questions. The other thing I want to suggest, and the way I think about it, is that there's a difference between evidence gaps and research needs. So to me, an evidence gap is, at the end of a review, for example, or evidence synthesis, and the reviewers couldn't make a conclusion about one particular aspect of a question. That's a gap. That doesn't mean that it's necessarily a research need. A research need is a gap that limits the ability of a healthcare provider, a patient or caregiver, a policymaker to make a decision. So to me, the gap is sort of the start of the process, and there are some other steps that need to take place. And Wanda was actually involved in this study, but to me, there are a number of different ways you could go about it, but the generally would be identifying and characterizing the gaps, going through some process to get stakeholder input, whatever this appropriate stakeholder would be, to help refine those into needs, and then to prioritize those needs. So moving back to gaps, I did want to mention one project that we did before the development of the framework, which Alex talked about briefly, and I'll go into a little bit. And that was a project looking at guidelines. So our idea was similar to systematic reviewers, guideline developers, probably maybe even more so than systematic reviewers, are ideally situated to identify where there are gaps. So as a kind of preliminary step, we did a little pilot study looking at some evidence-based guidelines, and we identified gaps, what we consider gaps, as those eyes, those dreaded eyes, where no recommendations were made. Also, in this case, there were some cases where the guideline panel decided a priori that, look, the evidence just isn't going to be there. We're going to go straight to a consensus recommendation. And then also, if the guideline panel explicitly said needs further research. And what we found was a lot of gaps across the 5 guidelines, 62, but only one of those were fully specified in a way that you could have a research question. And since these guidelines were treatment focused, then PICO was the framework we were looking at. And then only 20% of those gaps were actually called out by the guideline committees as gaps. So they might have said that it was insufficient, but at the end, there wasn't a formal presentation of, these are the gaps. So it was difficult to tease out. So Alex mentioned this work that I did through the EPC methods work groups, an initial development and then an evaluation of a framework. And to me, what we wanted to do was to not only identify gaps, but to really characterize those gaps in terms of why they were gaps. In what way did they fall short? In what way was the evidence inadequate? And so these 2 pieces. And we created a worksheet, and I won't go into this in much detail, except to say that, as you heard, that we use PICOs as a framework, again, thinking that to effectively spell out a research question, we should have the PICO elements, or map it back to the research question. One thing I would, as an aside here, say in relation to Alex's comments about implementation, we were focused on, in EPC jargon, comparative effectiveness reviews or treatment reviews, but it may be more appropriate to use other question frameworks. So there's a framework called Perspective, which brings in setting and context a little bit more. There's one called SPICE, for example. So I think it could be, you could adapt something like this using the different question frameworks. The other thing on this worksheet was we had the reason for the gap. And I just wanted to point out that we did map these to the different grading systems, to the EPC strength of evidence to grade and to the USPSTF grading system, and provided a code sheet with the worksheet to help people figure out which reason or reasons they should code. And then what we did was evaluate the framework by retrospectively applying it to 19 EPC reports and 31 Cochrane reviews. The structure of those reviews are very different, as most of you probably know. The EPC reports typically have many more questions than a Cochrane review. And they may include different types of evidence to a greater extent than Cochrane reviews typically do. So this was a lot of work, and Tianjing was on this project. Thank her for her help on this. We identified across those reviews 600 unique research gaps, several per question. And the most frequent reason was insufficient information. So this lack of studies were too small. And I was actually, honestly, a little surprised that biased information was one of the lower ones and not higher up. And I will say that you see the little picture of the report in the bottom. That's kind of where this ended. So there, I'll get to this in a second, but there was no uptake of these gaps by any funding agency, by any policy agency. We didn't actually publish this separately then from the methods, publication that you see there on the bottom. And so that, I think that's an issue. And so I wanted to end with some things to maybe think about for the panel. So I think it's important that we systematically identify evidence gaps, and that we do both things to identify worthwhile questions, so questions that need to be addressed, but also identify and characterize the gaps in a way that helps to inform the design of studies to address those questions. So not only where the evidence falls short, but how or why the evidence is inadequate. I will suggest, again, that gaps are not the same as needs. And I think when you think about prioritization, there are some other steps and activities that need to come into play. Also, having done this and done the framework application, think about who does it. So is it the EPC or the systematic reviewer? Is it at the end of our systematic review? Is it retrospectively? Is it the guideline developers, the USPSTF panel? Who does it at what time point? I will say it was very difficult to, it made it challenging to apply retrospectively because you're relying obviously on what was reported in the reviews. But on the other hand, the reality is that as most of you know, the EPC projects in particular are contracts, they're time sensitive. At the end of the review, the last thing the review team wants to do is sit down with the worksheet and fill that out. So that's also a concern. The other thing to think about is what's the product or what gets reported back. So if it was the reviewer that's filling out the worksheet or doing some other form of taxonomy, how is that presented? Who is it presented to? Does anybody really care? Sometimes we feel like, that if the tree falls in the forest, is anybody, if nobody's there to hear it, does it really fall? To whom are the evidence gaps presented, and who will take it up? And so I end with maybe a bit of a provocative question or comment, and that is, I'm not sure a new taxonomy is needed, but definitely some help around process, when I say it, is needed, about who does it, at what time point, how does it get into the pathway with funding agencies or other policymakers. I think, to me, that would be a huge, I understand it might be beyond the scope of the statement of task, but to me, that would be much more, would move the field forward more than yet another taxonomy. And again, I'm trying to be a little bit provocative there, and I'll end it there. Thank you.
Okay, that's great. Thank you for challenging us to think. So thank you so much, Karen. And why don't we go ahead and switch gears and look at Sue.
Oh. Okay, I think I got it. Can everybody hear me and see my screen?
Sounds good.
Okay, great, thanks. Also disclaimer, these points really represent my own opinion. They don't represent NIH or ODP or AHRQ or any other part of the alphabet soup that's represented today. And I do want to thank you for the opportunity to present. I've already introduced myself, so I won't do that again. And I'm really looking forward to the discussion. So I just have a few slides and they're very top of the trees. Alex talked about the number of topics and letter grade recommendations and so forth. And I did just a quick count at the website yesterday, so I may actually have this wrong, but I counted 85 topics with 120 letter grade recommendations. 38% of them had a letter grade of I. And all of the recommendations, as has been noted, have a very brief statement of research gaps. I want to make a couple of comments about research gaps and taxonomies. If this was easy, it would have been done by now. So, I just want to acknowledge that the committee has a difficult task, but it does have a lot of shoulders to stand on, including the great work that Karen and her colleagues have done, all of the work over the years that the task force has done to codify and make transparent their methods, as well as all of the work and methods of the EPCs in general, and the work that NIH does. They take these research gaps incredibly seriously, as do investigators. So just a couple of editorial comments about that. And for some reason, my slides are not advancing. Okay, there we go. Why are we doing this? So one of the things that we're not really talking about yet, in this, I'm sure the committee might have, is that from the task force perspective, yes, all of the recommendations have research gaps, but I statements are really important. There's quite a rigorous process that the task force goes through before even deciding to look at a topic. So the topics that are in our portfolio are important topics that have the potential to improve the health of the nation. And having spent a decade on the task force, and we try to update our recommendations every 5 years, which means that after 2 to 3 years, they get into the cycle of updating. I've been through multiple rounds with a recommendation where we can't get off an I. And sometimes we can't get off an I because no research has been done, but even more disappointingly, sometimes we can't get off an I because new research has been done, but it wasn't done in a way that allowed us to aggregate across the new research, and it wasn't informative. And secondly, as we've talked about a lot in the first session, the task force wants the ability to make recommendations for all key populations. And right now we only have the ability in many cases to make recommendations for some, but not all. From the funders' perspective, there's a lot of research gaps and there's not a lot of resources. And so funders do have to prioritize amid these many research gaps. And it's difficult to do that. So I've heard conversations where funders will say to the task force, tell us what the most important gaps are. And the task force will say, no, they're all important. And so, there you have it. Okay, you're at a stalemate. Also, funders would like specificity regarding study designs. If we're going to invest money, maybe just tell us exactly what we need to do. Now, yes and no. Investigator-initiated research is important, so you don't want to be too prescriptive. So that's another area that can be difficult. And then the scientific community, we want studies that are designed for aggregation and dissemination. And I think investigator-initiated research is wonderful. I had the benefit of doing that for most of my career. But I also remember having quite an exchange with the Cochrane Collaborative when one of my studies was omitted from a review because they said it was a flawed design, and I had to go back and forth and show them that in fact it wasn't. So we do care about our research being able to be included in aggregation that leads to policy and guidelines that lead to better health. So what can a taxonomy contribute? I think first and foremost, a common language and a format for the task force, for the EPCs, for NIH and other funders to communicate amongst themselves. So we don't have a Tower of Babel. Second, it could provide objective criteria for prioritization of funding initiatives. I won't call out a specific question, but there's one recommendation in a prominent area. That's an I recommendation for people over the age of 75 for screening. And everybody knows we'll never do that study, but it's always there as a research priority. So is there some way of codifying or looking at some of the research gaps in a taxonomy that might be helpful? And then obviously it provides an opportunity for researchers to design and implement impactful research. And I've talked about impactful research as research that gets used. So what would be the attributes of a taxonomy? What are we aiming for? I think there's just two things that I would really, really emphasize. The first is credibility. No one's going to use it if it doesn't ring true. And I think for this taxonomy specific to the task force to ring true, it needs to recognize and respect and understand the EPC and task force methods. This is not a consensus committee to redesign the methodology of the U.S. Preventive Services Task Force or any others. One way of respecting and recognizing and understanding is to have a taxonomy that uses the available resources from evidence reviews and evidence synthesis. And so I'm someone who would argue that most of what we need is there. It just isn't organized in a way that allows us to take advantage of it. And then it's going to have to be simple. It cannot solve all the problems. Research designs, I think having some insights from the consensus panel about the types of research designs that would inform the types of evidence gaps that are in the taxonomy is incredibly important. But I actually trust the scientific community to know what a solid research design is without having every little bit spelled out, but understanding common outcomes, understanding sample size, understanding where in the analytic framework you are. If you're trying to relate intermediate outcomes to health outcomes, which is incredibly important because, as Karina noted, we mostly get to recommendations through the indirect route. Having a taxonomy that encourages all of that and builds on what we have would be incredibly helpful. And so simplicity is the ultimate sophistication. I found two quotes about simplicity that I happen to like, so I thought I'd share them. That's a quote from Claire Booth Luce. And if you can't explain it to a 6-year-old, you don't understand it yourself. That's actually attributed to Albert Einstein. I'm not saying we're trying to develop a taxonomy for 6-year-olds, but I do think that the easier and clearer and simpler the taxonomy is, the more credibility it will have, the more likely it will be to be used. So I think there is a natural tendency in these kinds of activities to try to cover, everything and to be as sophisticated as possible to show that we know what we're doing. But I would argue that simplicity, even to the point of, red light, yellow light, green light on, telling us something about evidence gaps could be a helpful exercise. So I'm going to stop there and look forward to the conversation.
Okay, great. I was just reflecting that we have so many years of experience among our panelists with the task force and the EPCs and all of the processes that go into trying to address evidence gaps. It's really quite an assembly of collected knowledge and wisdom. So thank you for bringing your perspectives for us. I'm actually going to pull up my participant list and invite the committee members to jump in and ask any questions. I have some questions, but I want to invite my fellow committee members to get into the mix of the conversation. So let me pause. So Tianjing, why don't you start?
Sure. Just a lot of things for me to reflect on, and especially hearing all three speakers. And this question probably goes to Karen and Alex. I think, Alex, you mentioned about the implementation gap and dissemination gap. And then Karen, you also mentioned gaps are not equal to needs. So between those things, I think there's a problem of prioritization. And I wonder how much of the taxonomy will also be applicable to prioritizing research.
Yeah. Alex, do you want me to start?
Go for it, and then I can jump in.
Okay. So hey Tianjing. A couple of things. One is that, as I said, the PCOTs may not be the most relevant question structure for implementation questions or gaps. So I would look, again, there are existing question structures around that. And then you raised a point that, I sort of raised in the last page, is that it's not clear to me how a taxonomy can help prioritize. To me, if you're talking about prioritization, then you're already talking about research needs, which again, to me is a little different. And this is also related, which is not quite what you asked, but is also related to the issue of how people apply the framework that we developed or other frameworks to reviews, for example, is we're looking at specific gaps, but not all of those gaps are useful for the USPSTF or for the public or for the policymakers. And so again, if we're talking about prioritization and implementation and other sort of factors, I think it would be helpful to be explicit about, to me, that difference between an evidence gap and a research need, and what do you really mean? What is the taxonomy really providing?
And I'll add to Karen. I think I agree with what she said, and some of it, and I'm going to give a couple examples too. If you're thinking about sort of prioritizing, I think how things are prioritized depends on the topic and where the state of the evidence is. So, a D&I type of a question on an I service is very low priority. I mean, we're not going to disseminate and implement something. And the other thing I'll go on to say, but then like my example of smoking cessation counseling, something that's very well established might have a higher priority. Building on what Karen said, I think some of it also will depend on the goals of the committee, right? If you're trying to develop a taxonomy to close evidence gaps, the D&I gaps become less important, just to be transparent. On a task force end, like a D&I gap becomes really important in communication. So if you think about healthy lifestyle counseling around diet and exercise, some evidence gaps around how the intervention looks, how it's implemented, how it's put into place might be important for us to communicate the recommendation and for clinicians and health systems to adopt it. But it might not be important to change our B or our C recommendations. So I would just put it out there about thinking about what the goals of the committee are with the taxonomy and the nomenclature. It is important, and it is important to make sure we're delivering it correct, but it might be out of the scope of this group. That I defer to you all on.
Well, so actually, Alex, I'd like to push a little bit more on what you just said. Number one, I want to echo Tianjing's compliments for the way that you both have structured thinking about this, and kind of along with Sue's comments on credibility and simplicity. It helps us see that part of the central challenge for our committee is that of scope. Are we looking, fairly narrowly at evidence gaps as Karen has defined them? In which case, honestly, Pi codes seems to work pretty well, and maybe there's not that much more to build out? Or are we looking very broadly at research needs in clinical prevention? In which case, there's D&I, there is, upstream access issues. There's kind of a whole lot of other concepts that one might want to use in terms of defining attributes by which you would prioritize a research effort. And so here's where I'm struggling. I'm thinking, we could build a taxonomy that goes very broadly and addresses D&I and equity and many of the other attributes that we feel are important in terms of researchers who may develop evidence or investments that research sponsors may make. I'm not sure that's going to be so useful to an evidence-based practice center, to people like Karen who are looking at the existing evidence and trying to classify it. So I'm trying to figure out actually who would take this taxonomy and say, great, I can really use this to have the next conversation. I'm starting to think maybe it's the research sponsors, because I've been on the task force. It's been many years since I've been on the task force, but from what I remember, it was kind of like drinking from a fire hose. And I suspect that has not changed. And so I'm actually a little bit concerned about whether the task force members or even the HRQ staff that support the task force will have the time to use a taxonomy that covers a very broad range of research needs, as opposed to the evidence gaps, where I do think that a lot of the taxonomy that has been developed served the purpose quite well. So maybe it's the research sponsors that we're trying to get to and say, can you think about these types of research needs in a more systematic way so that they can be prioritized? I don't know, let me ask our panelists to react on this. And Stu, I know that you've thought about this pretty broadly and you have your hand up. I'm not sure whether you wanted to respond to what was just said, but yeah, go ahead.
I'll try to be brief, which can be a challenge, I acknowledge. I think that this could be reverse engineered from what it is that we're trying to do. Because yes, I think a taxonomy is incredibly useful to funders, but then the funders are going to point to the task force and say, we can't fill this taxonomy in with the way that you have presented your recommendations or the way that the research gaps are described in your recommendation statements, because they're not as systematically described as perhaps they might be. And so, if you think about what it is that that we're hoping will happen in the conversation, because it has to be a conversation among EPCs, task force, funders, and researchers, and not everybody in the room at once, then I think that you can start to think about, well, what are the elements of this? And the P codes are incredibly informative, as is the analytic framework. But I would be a little bit concerned at having one audience without putting other folks into the equation and imagining what that conversation would be like. And maybe in another meeting, you might want to, pull in a task force member, a funder, and a researcher, and have them sort of, do the blind man and the elephant with research gaps, in an important I statement. What is this telling you? What is that telling you? I think everybody is doing their best work. I just think that it's not coalesced around a common, simple framework and language for communication.
And Tracy, I'll jump in because I was not trying to be too narrow by pointing out about the D&I. I want to be clear about that because I think it is important to think about that. And I probably should have put this in my slides. We've got a diagram about like the knowledge cycle. You have research, and then the EPCs, analyze the evidence. there's a guideline, we identify the gaps, and then that goes back to the funders and the researchers. I mean, I think they all have a role in it, to answer your question. And one of the things that we have done on my time on the task force, we're doing it right now around how we're approaching the issue of sex and gender as an example, is that we'll regularly pilot things internally. We'll try to go through and use a taxonomy, try and change and adapt our language, try and field a new method. So it is like drinking from a fire hydrant. I don't disagree with that at all. And we have a meeting next week that I'm preparing for, so I'm drinking from that fire hydrant now. But to your point, though, I think there is a little bandwidth where we could take what comes out of this and try fielding and implementing and using it to try and be a little more systematic in our approaches. But you can imagine those different groups in that life cycle, each could have their role, each could take a piece of this and use it the way they would. And I mean, I think your recommendation is going to be fabulous, but it'll be the beginning of a longer process to kind of continue to refine and update and move this forward.
Just to add on a little bit and maybe repeat myself a little bit, I really think that the committee would serve the field at large best in thinking about the entire process. And part of that is thinking about, to what end are we applying a taxonomy? I mean, just to give you a kind of a concrete example, as I walked through with you, when we applied the framework that we developed to existing reviews, I mean, for the EPC reviews, we got an average of over 12 gaps per question. So yeah, we can do that. We can apply a taxonomy to that, but is that useful to the USPSTF? Is it useful to a funder? Is it useful to somebody else? Probably not. So there needs to be some structure or guidance as to what end is the taxonomy being applied. And again, as I said, what's the end product and who is it being presented to what end? So I echo, I guess, what Sue is saying, and I often say this to our EPC teams is, think of the end product. What do we want to be able to present and answer? And let's work backwards to make sure that we can answer that.
And looking at my fellow committee members, I can jump in with another question, but I'd love to hear from you. So Ian, you have your hand up.
Yeah, thank you so much for the presentation. I learned so much about different framework, and I do agree that building on the existing work, there's like, when we're trying to use in the framework, I think every framework has the benefit and has limitation. And so what I heard from this discussion is I heard about implementation perspective, but also heard about who and how and why. And so there's a different audience. And I also heard about simplicity and credibility. So those are like very helpful to think about like how to conceptualizing applying taxonomy. And so one way that I'm also like want to hear more about is that is it the approach focusing on consumer, focusing on practitioner, those kind of way of thinking about taxonomy, or like using more multi-level combined, like implementation is already multi-level, but thinking more about different target audience. And so I think some of the evidence gap is really depends on who we're talking about, and usually it's coming from practice side and also the consumer side. And so it could be something more dimensional thinking, because I was also thinking that health disparity framework, it's kind of moving toward that direction. Same thing as mental health framework, it's also moving toward multi-level, multi-dimension. It's not going into too detail, but at least there's some dimension layer that we can think about. And so if we're coming from saying like we're looking at the population, that's more like from a consumer perspective, how do we adjust the gap, what are the dimensions we need to think about? Would that be one way to, like, I mean, it's simple enough, capture the big dimension, but also have enough guideline in terms of which dimension to think about.
Okay, let me look to Sue.
Oh, sorry.
Yeah.
Go ahead.
You know, I really think the genesis of this is helping get research done that's going to make a difference in having evidence-based preventive guidelines. And that's the foundation on which all of these other desirable things builds. But I think, you know, that to me is why this committee exists. It's to ensure that, and that's why NIH and AHRQ are co-sponsoring this. You know, and not that other things aren't important, they're incredibly important, but you know, if you can't make recommendations for prevention because the, you know, I don't know, it's something like 75% or 60-some% of resources in prevention research come from NIH. They have a huge investment in this. And nobody wants to repeatedly say, we don't know what we can recommend to help prevent risky drinking among adolescents. And then you have an institute that says that's really important, and they fund several new studies, and none of them can be aggregated because they're in different populations, they have different outcomes, they have different timeframes, so on and so forth. These are real issues, you know, that exist in the guidelines, and I think it's important to, you know, help sort of pick some existing guidelines that didn't have a systematic way or a taxonomy of attaching to attach to research gaps. And had there been one, it might have been much clearer to the funder. It might have been much clearer to the investigators that, you know, we can move this field forward by addressing this important question, but making sure that we do it in a way that allows an analytic framework that has already existed to be implemented and for the research to be aggregated in that way. So, you know, that to me is the beginning and the end of the most important part of the work that you're doing.
Okay. That's very helpful. I see Karen and Shaik, and yeah, why don't we just keep going down the list of people who'd like to speak? So Karen.
So I just wanted to respond to something I heard Yen, I think is that your name, Yen, say, and that was a question whether when or how to bring in different people's perspective or different stakeholders' perspective, so consumer or policymakers. I think that's what you were saying. And to me, again, if we're talking about a couple of things, if we're talking about different perspectives or about a gap, then that's moving into the realm of research needs. So to me, an evidence gap is, as a reviewer or as a guideline member, I couldn't make a statement, I couldn't make a conclusion about this. If we start talking about prioritizing or having different perspectives, then we're moving into research needs in my mind. And the other sort of related factor there is, quite bluntly, we cannot ask an EPC or another systematic reviewer to apply taxonomies from different perspectives. That's not their strength. That's, you know, that's not what they do. That really needs to be applied by those people, you know, like the James Linden Alliance gets input from consumers, you know, funders or other things should apply those perspectives. That's not what the systematic reviewer should be doing, in my opinion.
That's very helpful. So thank you, Karen, for kind of clarifying the scope of what the reviewers do. Let me look at Shaik, and you've been waiting to say something.
I'm not, I hope I can make sense. I mean, oftentimes when we're trying to solve a problem, it's good to know what is broken. And sometimes in the course of this conversation, I'm not sure I understand clearly. So if I am to hazard a guess at what I think we're trying to solve is to create a process by which the U.S. Preventive Services Task Force will more clearly articulate the gaps. And so going back to sort of Karen's points and the points of others, then in my mind, I'm thinking about the EPC coming up with a list of evidence gaps, which I think is quite done reasonably well right now. We don't have a framework to hang on it, but the P-cuts, in my view, sort of a decision matrix helps to create that. So is it sort of the P-cuts on the prevention and the dissemination pieces downstream do that. So is that what you are doing? And I think that will help. And I will again sort of, since I have the mic, make the plea that we don't forget the issue of, and so I get it, we don't forget the issue of equity, because I think in my mind, when we talk about improving the health of all Americans and the gaps that exist, whether they're I's, A, B, C's, or D's, some of the biggest gaps are in implementation. And I think Alex made that point very clear. So it's not just so much about the recommendation statement itself, and I appreciate the I statements, but the biggest opportunities sometimes exist in those ones with an A, B, or so, and sometimes the implementation in the Ds.
Okay, that's really helpful. Yeah, I think, Chuck, you correctly observed that we are actually still trying to get more precision on the problem that we're trying to solve here. Let me look to Nico.
Thank you. Yeah, so I was still thinking about Sue's observation of this idea of credibility and simplicity. You know, so in terms of quotes, there is this other quote too that says simplicity is genius, but it takes a genius to be simple. So I'm wondering, can you give us, particularly in thinking about your Karen's observation about what's the product and what's the audience, what does simplicity really look like? Is it a set of design principles? Is it a set of process steps? Is it a series of roadmaps? Like, for example, a roadmap that gets us to identification, or a roadmap that gets us to prioritization, or a roadmap that's really all about process? Is it guidance steps? I'm not sure how to think about red, yellow, green, so to speak, but what does simplicity look like in your view?
Yeah, good. So that's a good question. Actually, I see that Sue and Alex have your hands up. I'm going to actually jump in and go a step farther with Nico's question, and maybe Sue and Alex can address it in what they comment back to us. So you mentioned that it's very, very frustrating when a particular recommendation has an I statement and repeatedly on re-review that evidence gap still exists. And so my question is whether the problems in those instances seem to consist of a lack of terminology or understanding of what needs to be done, or a lack of prioritization of what needs to be done. So is it that people are confused about what the evidence gap is and how to address it, or is it that the funder is not placing appropriate priority on the particular part of it? Let me stop and we'll look to Sue and to Alex.
All of the above. I mean, I don't think you can just answer it. I mean, clearly the example that I gave, there was prioritization, but I don't know that there was enough appreciation for the methodology of the task force, or that the requirements for those studies being useful to the task force were as transparently translated into the funding initiative. And you could say that may be because being on the task force for 10 years, I mean, I still relied on, the cheat sheets that were, on big cardboard pieces around the room in order to keep top of mind all of the methodological sophistication that's there. So it's not always easy to keep all of that, but I do think it's not that hard to communicate. I want to go to what does simplicity mean? And I'm going to this is top of my head. So, take it for what it's worth. But, start with these are the 5 things that we want to know. We want to know, is there a study or studies, and this is asking the task force to tell you this, that would, that we would look to answer this question. Is there a population? I mean, look at the P-coats, but the question is, what is it that we really want to know in order to move the field forward versus what would be nice to know, but we still are on an A or we're on a B or, we're on a D. And so I think that the reverse engineering, can start with those kind of conversations. So from the task force perspective, what do we need? What are the research needs that emanate from these gaps that are really going to make a difference the next time we go through this? If we were going to, when we update this recommendation, what do we hope we have in front of us? And how could you describe that in a very easy way? And if you want to get judgments from the task force, again, we don't do expert judgment in our recommendations, but you might be able to do judgments in your research gaps. Do we think that this is something that would be easy, moderately hard, or impossible to do? And if the task force, as we're putting this together, thinks it's impossible to do, then why even put it in as a research gap? It's never going to happen. So that's where priorities come in. To go to Chike's point about the importance of health equity, clearly that could be a very, is our health equities dependent upon answering these questions? And in some instances, we say that we have no reason to believe that this preventive service that we recommend for everybody shouldn't be done for everybody. And there's others that say we've got epidemiologic evidence that there are subgroups of people that have a different, that experience the disease differently, have different risk factors, and we need more information about that. Otherwise, we're never going to get to health equities. So again, from a simplistic point, I think it would emanate from, limit yourself to, 5 questions, 10 questions. Don't make it, 30 questions is what I would say.
And
it's interesting. I'm going to jump in and just say, Sue, something that you just said was really kind of about if you're the task force member and, what are the highest priority research needs that are emanating from the gaps that you now see related to a statement. I mean, obviously we need to make a taxonomy that helps everyone communicate, but it also helps to start with one point of view and who would be the initial user of this. And I do think that, maybe thinking about it in that way would simplify our task somewhat, because if we're trying to think about it from the perspective of a researcher, it's almost too broad because the researcher can write an R01 for anything they like. But if we're fairly concrete about it and saying, how could we, if I were a task force member and I don't have a lot of time, but I want to be able to relate to the sponsor of some useful research, what it is that I would prefer they invest in. And to be able to do that clearly, could we come up with a taxonomy that enables the task force to talk with a sponsor in that way?
I was going to say, I really like the question about what a simplicity looks like. And I want to put a couple pieces together, Sue talking about the 30,000 foot view. I mean, we're all interested in advancing the science and really figuring out how do we do these things better. And to George's points about, let's not be too narrow and just focus on gaps. What is the overall need? The overall need is advancing the science. I'm going to say the EPCs and the task force members know how to identify the gaps. There's not a problem there. I mean, we've got our methodology, we have our approaches, we can do that. Going back to your question, Yen, about who are the consumers, I'm regretting even more not putting that life cycle in, because I think we've got all those people that need to work together to move the science forward. And I'll tell you what I think the problem is it's the groups aren't working together. So, the EPCs are evaluating the evidence and defining with their methodology, which is exactly what they should be doing, the gaps. The task force is communicating in our recommendations. We try to do very plain language. We give our reports to Congress, and Congress and the ODP is trying to communicate it to funders. Simplicity to me looks like a process that's beyond that takes also the other steps of your charge, not just the taxonomy, but everything that happens with it. Simplicity to me means that it allows all these groups to collaborate and work together. So that's what we're talking about. I think that's what the problem is. We have each of these groups. NIH is great at funding people. They're great at a peer review process and figuring out who needs funding and writing RFPs. But how do you have something that gets these groups to work together in the same path, the same direction to try and advance the science here? That's a charge, but I think there's a way to do that with being more simple in sort of the taxonomy, people's roles. I had that whole workshop because researchers didn't know about this. So it's also about getting these ideas and this information out there. And how do you do all this? So.
These are incredibly helpful perspectives. I see that we're near the end of the session time. So I'm just going to take one quick look around the participant list and around my video. George, thank you so much for putting a lot of comments in the chat. Many of us have been reading them, and they're actually very helpful in terms of perspective. I know you haven't said much, but we will definitely, the committee will definitely take those into account as we're thinking as well. So I'm going to look at Kathleen. I think that it's probably time to bring this session to a close. Let me just ask whether you think there's any housekeeping or anything else that we need to do with our speakers or with the committee.
No, I think we just want to obviously thank the speakers, thank all the task force members who joined us. There will be a second session on March 16th, and we'll hope to have the agenda out in early next week. So we'd invite all of you, if you can, to come back on the 16th to listen to that discussion. If there's any other material any of you would like to send us or any thoughts, please feel we welcome it. Please feel free to email us or Alex, if you could send us your life cycle slide. And I think that's the end of what I might have to say, but thank you, everybody.
Yeah, thanks especially to Alex and to Karen and to Sue for bringing us your perspectives. It's been a really rich and